Well, while we're waiting, why don't I just go ahead and get started, and Bob will join us here shortly. So welcome, everybody. Thank you for taking the time to call in. This is the next in our planned virtual tumor board sessions. Today's topic is oropharyngeal cancer. We're very fortunate to have an excellent group of faculty joining us. Our speakers are Borat Urlagata. I apologize if I pronounced it incorrectly. Sorry about that. He's at the Leahy Clinic. Brianna Harris at CENTA. Brianna, I could not find what CENTA means. What's it stand for?
Actually, I don't think it stands for anything.
Okay, all right. I was looking everywhere. I couldn't find out what it stood for. So, Brianna had finished her fellowship at the University of Pennsylvania and is on faculty out in at San Diego. And Brian Cervenka is at the University of Cincinnati. So, without further ado, just in the interest of time, why don't we get started with our first case. Thank all the fellows for joining us and all the guest faculty as well. I know, obviously, Arnaud Bewley, Jeff Liu, Jeremy Richmond have joined, and I apologize. I'll look down the list here momentarily to try and acknowledge the others. So, Bharat, why don't you go ahead and get started with the first case?
Let me try to do this. I'm Bharat Yarlagata. Thanks for having me. Is this coming through?
Yeah, perfect.
Okay. So this case, 56-year-old gentleman presented with a painless right neck mass, 6 weeks, no other symptoms, no swallowing difficulties or throat pain or anything else. 40-plus pack year, more or less active.
Can you flip it to the presentation mode there?
Do what?
Can you flip it to the presentation mode? Yeah. It's just doing it like it's a slide there, but the slideshow, I guess.
How's that?
Perfect.
Good.
Okay. 40-pack year, smoking history, former alcohol abuse, now sober. About a 3-centimeter right neck mass, nothing on the left side. He's had a prior routine tonsillectomy in childhood. The fossa are normal. Base of tongue feels normal. Fiber optic scope is normal. CAT scan shows a 3.2 centimeter measured right neck mass, cystic, no other masses, no other nodes. They call a prominence of the right base of tongue on the CAT scan. The radiologist reported that way. Nothing on the left side. No other abnormalities. The needle aspiration biopsy showed necrotic debris with epithelial cells, but could not diagnose carcinoma. He had a PET scan done because of obviously a high suspicion of malignancy. The mass was avid, nothing else in the neck. Base of tongue showed a symmetric uptake, and there was no distant disease.
Why don't we stop there? We can, once you back up a slide, and we can just kind of pull the group here. So obviously you had a patient, adult neck mass, adult patient with a cystic neck mass. When we go back to the CT picture, if you don't mind. So just comment, what about that appearance made you more suspicious? You know, obviously age is a factor as far as it not being worried about or thinking it's likely not a congenital anomaly, but what about the appearance of that neck mass was more suspicious for you?
Well, level 2 location, and truthfully, I kind of approach it as it's cancer till you prove otherwise, and kind of level 2 cystic nodal mass, or rather just cystic mass. It was actually fairly otherwise reassuring appearance to it. There was no gross extracapsular spread, no other lymph nodes involved, no obvious head and neck primaries. So other than it actually seemed relatively a reassuring appearance. So it kind of, that's your classic pitfall that you hear about. But I kind of, I approached it as malignancy until proven otherwise, really.
I'm surprised that they approved the PET scan for you without a diagnosis of cancer. Might have been a good insurance company.
Yeah. I mean, I can't remember for him specifically, but sometimes that takes the phone call and the peer-to-peer to get that through, which is obviously painful, but it can happen.
So let me ask others, anybody else does anything differently at this point? And someone can mute their microphone. Who's on the call, Mike?
Jeremy, yeah, Jeremy, what would your any additional things you would do with the aspirate, and Borat may be getting to that momentarily, but say you get that result, you know, squamous cells can't be definitive, possible branchial cleft cyst versus any other questions you would ask the pathologist?
So was this an unguided ultrasound?
It was ultrasound guided.
Yeah, and just one ultrasound he's had so far.
Yep, with a fine needle. Mm-hmm.
Yeah. So, I mean, in my eyes, this is, you know, I agree this is cancer, but I would usually get a second ultrasound before proceeding to surgery, another ultrasound guided. I mean, they should have, so the things that tell you this is not branchial cleft cyst is that the wall is very heterogeneous, right? This does not look like a balloon that's just blown up. So you have areas that are thin and thick with cystic necrosis. So this is not a branchial cleft cyst, and there should be more than enough tissue on that wall that they should be able to get you a diagnosis. So I would repeat an ultrasound guided FNA.
Okay. I would agree. I would also pin it down. Going away from trying to do incisional biopsy or excisional biopsies, and I completely agree with Jeremy. And nowadays, with good pathology, good technique, we should be able to get a diagnosis.
Zender here. The other thing you can do too, and I agree with at least giving it a second shot, is that if you put one or two of those passes in the Cytol solution completely, so they've got a little bit more to spin down, sometimes you'll have enough in the cell block, they can do some P16 staining and other things too, versus if you just dump it all on some slides. And sometimes they don't have as much to look at there. So that's something else that sometimes with the second aspirate I'll do is put a little bit more in the Cytol for them to spin down and get a little bit more tissue to look at.
Yeah, that's a great point. We routinely here, we always send for cell block. If I do it myself, I always send a specimen for cell block, and our pathologists almost always routinely get a cell block. And we had very good success with determining P16 on FNA. When mostly we can just, by the next node, we can find out if it's P16 positive or not.
You know, our on-site people moved away from slide prep and go straight to cell block as well.
Right.
Would anyone get a core or request a core? Or does it really make a difference?
I only get a core if my pathologist is very suspicious for lymphoma, and I'm not going to take it out. But for these, I almost never get a core anymore. But I'm interested to hear other people.
I don't get a core on a cystic node like this.
Is anyone doing any ultrasound of the base of tongue and the tonsil, you know, through the neck?
I haven't done it.
In Indiana, we can't see that far, but I'm just saying for places that were a little thinner, you know, it's, I know, been described. I wouldn't be surprised if in the next 10 years it's refined much better. I know Carol Fakhry has written about it a bit, and their group has more kind of proof of concept studies, but a potential way of screening for submucosal disease when you don't see it on your office scope, you're suspicious they have an HPV positive tumor. Just bringing it up. I do not in my own practice do it, but I was just curious if anyone else was.
Nope.
All right, so yeah, why don't you continue, Borat?
So this, I think we didn't do a second needle biopsy. I think we had enough of a degree of suspicion from the first, and the patient wanted the mass out. He was feeling symptomatic from it regardless, that we went ahead with surgery at that point. So we started with direct laryngoscopy, looking for a primary tumor site. No obvious lesions were noted. Base of tongue looked clean. Soft palpation everywhere under anesthesia. And the mass was removed with a neck dissection, levels 2 through 4. And that returned as positive for squamous cell carcinoma. It was present in 1 out of 22 nodes. That was a level 2A node. And the pathologist measured it as a bit larger than the CAT scan did at 4 centimeters. That was and ended up being heavily P16 positive. And we can stop
Okay.
there.
So
No.
this is great because I'm very glad that you put up the P16 positivity. And that's one of those things that, as we do more and more P16, we have to be careful about the interpretation. It's very important to talk to the pathologist. Some pathologists are very good. They tell you that it's heavily positive. Some people say it's not very positive. But this is an obvious case that you can see how heavily it's positive. But we have to be careful with these, especially if you rely on FNA. If you don't know your pathologist, it's very important to double check these things. Now, did you take the node out and then do the neck dissection, or you just go ahead and did the neck dissection?
In that case, I just did the entire neck dissection from the get-go, kind of, just working off a high degree of suspicion.
Yeah, I don't think that's wrong, but in New York, we are in a very litigious state, and a lot of times, some of what when we do is we send the notes first to prove a diagnosis of a claim, and then we do the neck dissection.
On frozen section.
Yeah.
Yeah, I think actually a nice hybrid approach to both of those would be that you attack the area where that mass is in a in-block nodal level dissection. So you do a level 2 neck dissection and send it off for frozen. And that way you don't potentially, rupture the cyst and spill contents and so on. You're just still doing it in an oncologic fashion.
Yeah, exactly. That's a great point.
Brianna, what would you do as far as with that sort of a result with your next stage in the workup of this patient?
I would probably follow unknown primary protocol. If he had, any, I know you said he had a tonsillectomy in childhood, but if he had any evidence of any tonsils left, probably take it out and then consider even a superficial base of tongue resection. Because I think that even a PET scan can miss kind of a tiny primary. And that CT scan was pretty suspicious. And I think that the morbidity is so low with just doing a little lingual tonsillectomy that I'd at least explain the risks and benefits to him.
Would anybody do the TORS at the first get-go when you do the neck dissection?
I'd probably do it at the same time. Yeah.
I do as well.
I think that's one of the big differences because there are schools that they do delayed or first and separately, and some schools do. I mean, in Oregon, we used to do it at the same time, but there are a lot of places that they stage it, either the neck or the laryngoscopy. I don't know what the right answer is, but I think whatever works for you guys, I think should be okay.
Yeah, I think ultimately a lot of it's just logistics, right? So there's no wrong answer. Staging it has obviously demonstrated itself to be safe. If you have the capacity with the robot that you can do this and you start on the case and you potentially won't use the robot and you're not going to get your administrators upset with you, then that's fine. But certainly if the robot is a very precious and limited resource, then staging it is fine.
Yeah. All right, Brock.
Yeah.
What was yours?
So we did go ahead with a lingual tonsillectomy. This was staged mostly because I didn't have a definite diagnosis of cancer until the neck dissection final report came back, and also a lot to do with what Jeremy had mentioned. Our service doesn't have robot block time, so we'd have to book these out, and it just there's not a big delay, but it you kind of have to use it if you're going to book it. Is the situation. So for that reason, he had a staged lingual tonsillectomy done. And the way that I do these, they come out in 2 halves, and they're oriented on the cork board and marked and delivered to the pathologist so that there's really no confusion as to orientation and laterality. And
so tell us how you do this. Do you go all the way to the muscle, or you cut the cuff of the muscle? Where do you start? Where do you stop?
Make the anterior incision at the not quite at the circumvalent, but where I can visibly see the lymphoid tissue ending, and laterally to the glossotonsillar fold. But I try not to incise the fold because you start running into these superficial dorsolingual branches, and that can cause problems with bleeding. And yes, depth down to the muscle interface, and then posteriorly to the apex of the vallecula, kind of how I take it down.
And others, comment on the technique?
Question for you, Brian. Do you do serial frozen of these as you take them out, or do you send them just for permanent section?
I send them for permanent, and initially I tried just the one half, the suspicious half, and then thinking about bringing the patient back for the contralateral side. We tried doing frozens, but the pathologists just aren't equipped to honestly do that with the capacity that they have. So no, I remove both sides in full and send them out for permanent.
A little bit of a different technique. I'll take out just one half. I'll ink it. I'll bread loaf it, and then I'll serial section it and basically exhaust it with frozen section.
Yeah.
That way, if I do find, that way I can just start with one lingual tonsil if I need to, and if I can find in that lingual tonsil, I can spare the other side, and I can also re-resect the margin if I do locate it every time.
Arnaud, how many frozens per side? So you would only do frozens on the first side? Say that was all clear, and you did the other side. Would you just send that for permanent?
If I was, I would still look at it under frozen. So
how many frozens? How many frozen samples per side are you kind of bread loafing out of there?
Looking at that specimen, I'd say that'd probably be 7 slices, something in that range.
So majority of these are like less than a centimeter, as we know. The average tumor size is like 5-6 millimeters. I think like Arno, you have very good pathologists. I also not try to do cut the other side. I start with the ipsilateral side, and I haven't done sectioning, but I tell my pathologist to cut it at least 2 or 3 and look at the three different levels. But every once in a while you get one of those and you can't find it at all, and then you have to go to the other side. Let's see. That's Brian. Brian, what's your routine?
Yeah, so if you are talking to me, same thing as Arnaud. So we start on the ipsilateral side to the known disease, and sometimes we'll cheat a little bit beyond midline, but then ink it, take it over to pathologists, have them serial section, look for it. Of the 3 we've done recently, 2 of them they found it, 1 of them they did not on frozen section. And I'd say the big benefit, I've noticed in getting a diagnosis early on, or with frozen, is 2 of them they call a close deep margin on frozen. So I was able to go back and take some extra just to make ourselves feel better with the final. I'm curious, what has been the experience with a half link, because all of them we've ended up with just taking out half. People doing a total lingual versus just a hemi. I can't imagine there's a huge difference post-operatively in swallow and how they function, but I'm curious if anyone here has had experience that's otherwise.
I mean, I can speak from the camp of doing a total, because I always do bilateral lingual tonsillectomy and have for many years now. So, I mean, functionally, we don't see any significant decrease on objective swallow measures, including video swallows, from a hemi to total. But again, all I do is totals. The one thing I'll mention is that we are developing a greater appreciation of multifocal primaries. And if your pathologist find one primary, then they oftentimes will not look thoroughly through the rest of the specimen. And so it's important to let them know that even if they find one primary, that they should be microsectioning the entire specimen and still trying to find others. And you'll be surprised that even in that contralateral lingual tonsil, every so often you're going to find another 1 or 2 millimeter primary.
Oh, that's a great point.
All right. Well, just in the interest of time, Bora, what did you guys do after that?
Yeah, so he ended up having a 2 millimeter invasive squamous cell carcinoma on the contralateral lingual tonsil, and the ipsilateral side was totally clean. The margin was close but clear, about 1 millimeter. That was P16 positive and was considered to be the primary site. And so for him, his final staging is at the PT1N2M0 left basic tongue cancer with a single positive node and no extra nodal spread. Primary site was excised with a close but clear margin, no other adverse pathologic features. And so I don't know what we're at with the clock, but the questions for the tumor board were basically, how do we manage the left base of tongue in terms of re-resection to distance the margin a bit? How do we manage the left neck, which has not been treated as of yet? Can we observe, and does the patient's smoking status have an influence on any of the decision making?
Why don't we just take one of our guest panelists, and then you can outline how you did it, just in the interest of getting to the other cases.
Sure.
So, Arnaud, how would you manage this patient as far as those point-by-point things he brought up?
I'm generally willing to accept a closer margin with oropharyngeal tumors. So I'd want to get a good sense of what that 1 millimeter looked like. But if it was, it depends. If it's 1 millimeter in the muscle, I might want a deeper margin. If it's within the capsule of the tonsil and the muscle doesn't look involved, I might accept that as a negative margin. The opposite neck, I guess, would depend on my decision on whether to manage the patient with radiation. And the patient, I think, if we were going to proceed with adjuvant radiation therapy, I would not dissect the other neck. If the patient was adamant that they wanted a surgery-only approach, then potentially I would consider doing a contralateral neck dissection.
Yeah. So that is. I'm sorry.
Go ahead.
I was going to say we did offer him a left neck dissection, and then observation, but he had enough of surgery by that point, and the radiation oncologist felt that the size of the contralateral node, they didn't feel comfortable with agreeing to observation. And so the patient went ahead with adjuvant dose radiation therapy.
Good. But no chemo, correct?
No chemotherapy. No, there wasn't considered.
And are your radiation oncologist comfortable with 60, not 66 or 70, because of the closed margin and all that nonsense?
Yeah, he was treated to 60.
Yeah,
that's what I would have recommended.
Yeah, I think that's the right answer. So you're taking someone that doesn't fit in the boxes perfectly, right? You have a small primary contralateral neck. That node was over 3 centimeters. So you have a number of reasons to treat this patient a little more aggressively with adjuvant treatment. I'm happy to push the envelope, and you can certainly make the argument to treat the ipsilateral neck surgically. But that really is kind of out of the box management for a case like this. The one thing I just mentioned is if your margin on the base of tongue came back positive, and your medical oncologist was saying, we have a positive margin, we need chemo, I would just push back very aggressively and say this was not an oncologic resection, right? Yeah. This was a biopsy, it was diagnostic, we found it, and we're gonna treat this guy as a small T1, N1, and radiation is fine.
Yeah. I'm glad you mentioned that, Jeremy. I've had, not in this case, but I've had to have that conversation, that's a good point.
And that's going to occur a lot with these diagnostic lingual tonsillectomies, right? You're going to have a microscopic focal margin, but that should not warrant chemo.
Oh, great. Fantastic case. Thank you for putting this on. This was as complex and as difficult as similarly looks like simple, but when you go down to it, there are a lot of decisions. Perfect. Thank you so much.
I was bringing up the next case. I just want to make a comment listening to all the comments. I think this is an important acknowledgement that the P16 positive oropharynx or unknown primary workup space is one that is highly debated amongst experts across the country. That has to do with, do you do surgery first and do the neck dissection? Do you, how do you sequence the TORS? If you do the TORS, do you do it ipsilateral versus contralateral? Do you do frozens? Do you do permanents? And then after you have as much information as you get a stopping point, is there a role for adjuvant radiation versus is it chemo radiation? So it's, unlike a lot of other diseases where I think larynx and oral cavity, where it's a little bit more structured and the NCCN guidelines are very clear, I think we're all trying to figure out for this disease, if it was a case where even one leftover cancer cell was going to be a recurrence, like we see with P16 negative disease, this P16 positive disease does well in many ways. We're trying to find the right way to sequence it with also the limitations within pathology, within your multidisciplinary team, and within your robot OR time. So I just, from the trainee standpoint, I realize that this is still a moving, area where I think a lot of experts are trying to figure out what is the best straightforward way to take care of these patients. And as you can see, a lot of smart people can treat it the same way and get success. But it has to do with rationale and understanding the reasons why you do things. Because I think it's a tough conversation from one expert to the other.
Totally. Who's next?
What do we decide more? Do you want to go with myself or Brianna?
I think Mike's in charge.
Go ahead if you
Mike?
get it ready once you load it, Brian. Great.
All right, let me get set up here. All right, can everyone see that?
Yeah.
Cool. All right, so go through a case show. Let me get this pulled up. We have a 55-year-old female, 10-pack year history of smoking that presented to us from October with 2 months of right-sided throat pain and associated right-sided neck mass. She's initially seen outside, is often the case in our area. Had an FNA done that demonstrated initially P16 negative squamous cell carcinoma, and then she was sent in for further evaluation. And so because of her initial P16 negative and wanting to see if she was a good TORS candidate, we actually took her initially and got a repeat biopsy of that tonsillar area, which came back P16 positive by one of my partners. So when I saw her, she had a exophytic growth from the right tonsil, approximately 2.5 centimeters. Very minimal involvement of the soft palate or her base of tongue. It was mobile off the underlying pterygoid musculature. Normal left-sided tonsil. She had no trismus, good dentition, no TORS, nothing that would make her a poor candidate for a transoral approach. Her neck mass, she had a level 2 mass, approximately 3 centimeters, no overlying skin changes. Again, it was quite mobile. She was thin, no other masses or anything seen.
I was going to ask the group what makes a good TORS candidate, but you already gave it all up. Okay.
Yep. Yeah, that's true. So initially got a CT, ended up with an MR. She had quite a bit of dental artifact and streak artifact that we weren't able to get a good look at the neck node as well as the tonsillar mass. So I'm just showing axial images from her MRI with contrast. You can see right-sided fullness asymmetry of her tonsil with what looks to be a preserved plane between that and the medial pterygoid muscles. Plane just showing an additional lower cut. Again, showing a preserved pterygoid plane there. Certainly something that should be resectable. Very minimal extension to the base of the tongue or posteriorly towards the prevertebral fascia. Showing her neck note here. Again, it was actually longer in the transverse, but again, no evidence of any obvious spread into the adjacent SCM or anteriorly towards any other structures. Again, obviously it's a difficult call to make on imaging alone, but nothing was concerning on this or on exam.
Yeah, there's 2 more. Yeah, you want it?
And again, looking at the coronal, same MRI sequence, asymmetry of that right side, no obvious invasion of pterygoid musculature. Again, a node that looks to be well encapsulated. Nothing else concerning. So we talked to her about her options based on this. So at this point, we had staged her at clinical T2 on M0. She had negative chest imaging as well. And so we talked to her up front about her options, obviously, which would be radiation therapy, primary radiation therapy versus transoral robotic.
What would you recommend, Brian? Forget about the options, your patient.
Yeah. So she's a great candidate for TORS, and that's the direction we ultimately took this.
How often do you guys rely on MRI? I'm just curious to ask the group.
Not,
others, Jeremy.
Yeah. So not all that often, only if someone has artifact or something where it's not completely clear. Interesting, our radiation therapist who saw this patient as well was a little bit more concerned about the mobility of the node, and with combination with the artifact, wanted to get some additional imaging. But not something that all that typical for us.
Can I just point out how helpful those NCCN guidelines are? If you go back, where it says you can do anything. Right?
Right. They're comprehensive.
It's like how helpful is that? Like you can do radiation, you can do chemo-rad, you can do a clinical trial, or you can do surgery. It's awesome.
Exactly. And that was the point, okay, You have
You
all the
feel like a winner, regardless of what you do.
There you go.
It's
Yeah,
true.
you made the right choice. Yeah.
But
Make you
I
feel
think
better.
Brian's point about the radiation therapy, and this is for the younger folks on the call, you want to build relationships with your radiation oncologists. You don't want to be the guy or gal that just rushes people to surgery before they're presented at tumor board. And ultimately, if you're really going to de-escalate therapy in some of these folks, you got to have buy-in from your radonc and medonc partners. So the other day, I actually presented a patient options with the radiation oncologist in the room, and luckily she didn't throw me out, and the patient opted for TORS. But that being said, having a good partnership, understanding the patients you're going to radiate, you're not going to radiate, and minimizing triple modality therapy, having good partners in the other domains is critical for these patients.
I think one other point, and kind of to go back to what Jeremy mentioned in the first case, if you can really define if it's going full thickness on the constrictor, to discuss that at tumor board, because by definition then, if it does, you can resect it and you can resect the neck, but you're going to have a quote unquote abutting deep margin.
Yeah.
And you don't want that to, if you're going down the path of surgery with the goal of avoiding chemotherapy and you accomplish everything you wanted to with surgery, and then they come back and say, oh yeah, we're going to give them chemo anyway. You can have that discussion ahead of time almost, based on, if it looks like on imaging, it's starting to pooch out into the parapharyngeal space.
All right.
It's fine one way or the other, I think, disease control wise in reality. But to have that discussion at a time, make sure the patient is informed in a decision. It's kind of institution dependent whether they're willing to allow for you to withhold chemo if there's a clean plane of separation and it's just butting that margin. But I think it's just important to talk about that up front so you make the right decision as a group.
Agreed. All right. Continue.
Real quick, out of curiosity, Mike, ones where you're worried about the size or for whatever reason that you're going to be closer, have you found, again, MR versus CT or any specific imaging modality helped, or is it really just use what you got? And
a few curtains reading it at Mass Eye and Ear, yes. The MRI is spot to be, I think, a little better. But in ours, I mean, we got really good radiologists, but I think in reality, I still think we usually use CT. And just I think those
one thing I would say is, and medical oncologists and radiation say hello and order bazillion of scans. And I don't understand why we surgeons are so always reluctant to use technology. They are looking for some reason to think, oh, there's something here, something there. I would get an MRI every time I want to do a radical tonsillectomy. It just makes it much easier. You get the best view that you can. Obviously, it's something to chip shot, not a problem. But every time you want to talk about it with somebody and have an informed conversation, I think getting an MRI will show you the tissue plane so much better. It actually guides you. It's like a roadmap for you when you do the TORS.
Oh, we did.
And I don't think there's anything wrong with getting an MRI.
Yeah.
The moment you send to radiation oncology, they get a scan pre-treatment, they get a scan middle treatment, they get a scan and end of treatment, and then they order a PET-CT 3 months later.
Yeah, that's true. That's a good point. All right, so she, like I said, she elected to undergo surgery. We did at the same time start with the right-sided radical tonsillectomy with these. Again, similar to what we talked about with the unknown primaries. I like to take that back with a pathologist, ink it at the time, depending on the size of the primary specimen, either bread loaf the specimen or just take perpendicular margins to get a good sense of what our final deep margin and any of our close mucosal margins will be in case we want to do additional resection. At the same time, the patient was getting a neck dissection 2 through 4. They did lingual facial ligation. And then, anytime there's a lateral paddle defect, and this one just from the superior aspect of the margin, had some, we'll take just a little bit of that mucosa from the posterior aspect of the soft palate and just invert that with the posterior pharyngeal mucosa to try to close down the size of the port and help to minimize VPI. So she did well with the procedure. She did start a PO post-op day 1. NG was out shortly after, did fine, watched her for 72 hours per our protocol, just from a bleeding standpoint, and she went home after that. So final pathology, so she had a 2.5 centimeter tumor. All the mucosal margins were 5 millimeters or more. She did have a closest margin. This is something that comes up a lot, and I'm sure we're going to talk about. So they called her a millimeter at her deep margin with the constrictor, but ultimately it was negative. neck dissection. She had a single node at a 34 that was 3.5 centimeters without any ECE. So any discussion?
Well done.
Yeah, go ahead.
Hey, Brian, quick question. Do you typically clip lingual facial, external carotid? What do you do to prevent, the catastrophic bleeds?
Yeah.
Great question.
So I personally do lingual facial. Always, I don't take the entire external, but yeah, just lingual facial branches coming off.
Who does the entire external carotid? I'm just curious.
MD Anderson.
Okay.
I like to take little branches off the lingual and then the little branches off the proximal facial. I don't know. I feel like ligating the fascia could get backflow and you potentially wasted a vessel, but I don't know. It's just me.
Does everybody do something based on, kind of the reports out of 3311 and a lot of the literature now that supports it?
Yeah, I think most of us would do something. I used to do lingual and not facial per se, but I would find the pharyngeal and get those two. Nowadays, if you need to take the external carotid, you just take the external carotid. Tonsil is a little bit less than basal. Basal tongue, hopefully Brianna will talk more. That's the one that's really, when you get deep into the tongue, you're looking at a big artery. And then one question I wanted to ask Brian is, how do you approach your tonsillectomy? Do you start on the top? You go all the way? Just walk us through how you do it for tonsillectomy.
Yeah. So, I mean, it kind of depends.
1 minute.
What the cancer gives you, but for any of the more routine ones that are not deeply invasive anteriorly, I always start with the pterygomandibular raphe, make my anterior mucosal cuts, get through the constrictor. I find it's very easy to get the plane there. You can easily see the medial pterygoid muscles at that point and start developing that plane in the parapharyngeal fat space. At that point, I'll typically start to walk it around superiorly, so kind of pulling everything out. Again, you've got that plane established. You can see exactly where your cancer interfaces with the soft palate. I worry about that a lot. Again, these are patients who you're trying to minimize any morbidity. So trying to limit the amount of soft palate that you're taking unnecessarily, I find it's huge, especially as you're coming around posteriorly. So I'll watch that, flip it back and forth, make sure mucosally we're clear, but not getting too much. And then as I walk around posterior, you're going to end up in the posterior pharynx, deep in the plane at that point. Down to the level of the prevertebral fascial layer in continuity with that parapharyngeal fat plane. And then typically with that, once you've started that superiorly, I'll kind of lift everything up using my Maryland, and you'll see that space open up in the kind of retropharyngeal, and you can walk that down, making your mucosal cuts. And then at that point, I just start walking the entire specimen down. Usually, the plane is very easy until you start to get the level of the stylopharyngeus, styloglossus if you're that far inferiorly. Typically we'll take the stylopharyngeus, we'll kind of transect as it comes and interdigitates with the superior constrictors. That's where I always slow down a little bit and I always tell the fellows this, just to watch, because you'll get bigger vessels kind of coming in once you're deep to that stylopharyngeus. And then again, walk, and then finally we'll just make your decision about how much of your base of tongue. So this wasn't involved, and so you can get a little bit closer and don't have to take much. Obviously, if you have any extension, there I'll make that medial cut first and then pull everything towards myself and make the remainder.
So,
all right, so go ahead. Sorry, is there anything else?
no, that's your own echo.
All right. So we ended up staging her. So, by 7th, she's T2N2A with that 3.5 centimeter node, T2N1. So because of, she's a 10-pack year smoker. She had a 3.5 centimeter node, no adverse features on that. And then the 1 millimeter margin, we did discuss radiation therapy with her. She met with our radiation therapist, but ultimately did refuse radiation therapy. And then we did not discuss chemotherapy with her.
Let me do a,
So
go ahead.
Stop PET scan. Okay.
Okay, perfect. Can we do a quick poll? Who would have recommended RT? I would probably recommend RT, but I'm curious to hear. Big note, smoker. Let's just do a quick poll. Let me see who's on my queue. And while you're doing that, can Brianna please bring up your presentation?
Yeah, I would have given it. I would have recommended it. Yeah.
Okay. Jeremy?
I'd be on the fence. I could go either way, but you know, board answer is you have a classic close margin and you have a node greater than 3 centimeters, so you have to at least recommend radiation.
Chad?
No, I agree. You know, just in terms of that close margin, you can judge me if you want, but if I notice that's close intra-op, a lot of times knowing it's going to be a hard argument afterwards, I'll take a little of that buccopharyngeal fat,
Sure.
or I'll take a little bit of the palatal-glossus or palatal-pharyngeus, whichever margin I think is closest, and send that as a separate deep margin so that you can argue during tumor board that you're clear. But I mean, again, I think you have to at least offer the patient radiation because of the factors that Jeremy mentioned.
Okay. All right. So this is like a congressional hearing. Yes, no. Bharat? Yes, no. Okay. Perfect. Arno?
Yes.
Okay. Jeff?
Radiation, yes.
Okay. Perfect. All right. So I think we have quorum. I agree that. So for the audience, these are difficult conversations and we all want to avoid it. But at some point, you know, you look at everything and you have to decide. Okay. Can Brianna bring up your
Yeah, sorry,
presentation?
I can't start sharing until Brian, there we go.
Yeah. Yeah.
All right. Is this working?
Yeah.
Yeah.
If you put on presentation mode, please.
Oops. Sorry. Come on. Okay. So this is a 60-year-old male. He had intermittent sore throat for 3 months, treated with antibiotics by a primary care physician. Then a right neck mass appeared. He had an FNA, which was non-diagnostic. The PCP, interestingly, ordered a PET CT next, which was approved. And he was sent to an outside provider who did a pan endoscopy with a biopsy of a right base of tongue mass that he had seen, which came back as P16 positive squame. He is a never smoker, social drinker, no real past medical history. And he got sent to me on physical exam. He had about a 2 centimeter mass in right level 2 and a large right base of tongue tumor approaching the midline. Hopefully this will go. So this was his PET CT. So as you can see, pretty large hypermetabolic area. And then this sort of touches on our other discussion. I prefer MRI for these, particularly if I want to consider TORS as an option. I find that tonsil and base of tongue in particular, I think that MRI is more clear. So this was his MRI, his mass, and I have a solid picture there, but I can also pause it. So I guess, I brought this to the tumor board and asked what treatment options you guys would consider.
So how big is this?
It was just under 4 centimeters, they said on imaging.
Oh boy.
Brianna,
Okay,
was there a contralateral node?
So there was a question of a contralateral node on the imaging. See if I can pull that up here for you.
I think I'm already ready to check it out on this one, but let me ask others. Let's see. Who is? Let me just pick up 3 people. So we're gonna ask Arno first, then Jeff, and then Jeremy. Let's go.
Yeah, I have the same gut as you, Babak. When it starts getting that big and really involving both sides of the tongue, contralateral adenopathy, I think this is potentially resectable, but I worry about the morbidity of intramuscular margin on both sides of the base of the tongue with a bilateral neck dissection. I start to worry about long-term swallowing morbidity. So this would be one I would be probably inclined towards chemoradiation rather than primary surgery.
Jeff?
I agree with Arno. Our team has made a decision that if the patient is going to need bilateral neck dissections as part of their surgical treatment, that there should be a consideration for chemoradiation. It's sort of like a soft team agreement. So I would lead toward chemoradiation. But based on the imaging as well, it really does look like it's at the midline, if not already on both sides already.
Okay, Jeremy, you get the last word.
I agree. So I would say that contralateral node is a little more than suspicious. So I would say it's an N2 disease, chemoradiation. I will just say if the node is really borderline, then we oftentimes will do an ultrasound guided FNA on that contralateral node to try and drive which way we're going to go.
All right, Brianna.
Okay, so patient, his two things. Number one, he had such a bad experience with his first FNA, and at tumor board discussion, they said, we're going to treat the other neck no matter what, if that's positive or not. So, you know, you can get an FNA on that side if you want or not. Patient's brother-in-law had chemo RT for a similar cancer, and he was adamant that he did not want chemo RT. I thought I could clear the margin. So being young and very confident, I was like, oh, I could definitely do this for you. But anyway, so he was really adamant that if I could spare him chemo, he wanted surgery. So we took him for the bilateral neck dissection, the base of tongue resection. My paint by numbers is not that good, but he did well. We kept him intubated overnight, and he got extubated, passed his swallow. He did very well.
You did one session, both base of tongue, bilateral neck?
Yep.
When did you get home?
1 p.m.
Okay. Oh, very good.
So he did well, but surprisingly, pathology came back actually as poorly differentiated basaloid squame, which was different from his biopsy. So that was our surprise. Diameter was 4 centimeters, depth of invasion 9 millimeters. He had PNI, but he only had one lymph node positive. The entire contralateral neck was negative. That lymph node was 1.8 centimeters, and there was no E&E. So his final pathologic diagnosis was a P2N1. So who would now give adjuvant therapy?
So before we go to the adjuvant, there are two questions from the audience that I would like to open for the panel. Question number one is, do you all place NG tube in the patient intraoperatively? Or what are the thoughts? And number two is, in anyone routinely doing retropharyngeal lymph node dissection, either during the TORS or during the neck dissection? So two questions from audience. We can, whoever wants to pick them up, but let me go first. I think this is a big tumor. You have one node positive and you have PNI. So I would definitely do RT at minimum. I've been burned by PNI a lot of times, even when they are P16 positive. And let's see, Mike, what would you do? You're on mute. What's that?
RT, I would do it.
Okay. Oh. Arno is next on my line. Jeff?
Yeah.
I would advocate for adjuvant radiation for this case.
Yeah. All right. Let's see. Brian?
You already eat?
RT.
I don't care if mine's warm.
Like radiation, definitely. And Bree, what was the margin? What was the closest margin? I didn't see that.
I think if I remember the report, it was like 2 or 3 millimeters.
Okay.
On my first resection, one of them was close, and so I re-resected.
Jeremy?
Frozen section intra.
Okay. Chad?
Yes.
Okay. Anybody would do chemo? Chemo and RT.
I don't think it
Big
makes
tumor, close margin, you know.
You know, I think you, if you did the resection, if it's a negative margin, it's a negative margin, and it's pathologically negative. They're always, you guys know it's always pretty close, but this is negative, and you have a single, looks like ipsilateral lymph node. So I don't, without evidence of E&E, so I would not advocate for chemotherapy. But the only reason I'm advocating for radiation is because of the generally larger primary site that I'm just concerned about.
Yeah. And Brianna, what did you do for the vessels?
Clipped him on the ipsilateral side, so lingual facial.
Lingual and facial. You didn't ligate the external carotid. Okay. And question from the audience, what's your post-op routine in terms of feeding tube, feeding and stuff?
I routinely place a feeding tube in them and then get a swallow study on either post-op day 1 or day 2 while the patient's in-house. I keep them in-house for 3 days. If they don't pass, I send them home with the feeding tube and outpatient SLP follow-up. Otherwise, NG tube comes out before they go home if they're tolerating enough PO intake.
Mm-hmm. Okay. And let's ask you first, and then we ask others if anybody has different. What was your approach to retropharyngeal nodes? Usually they apply to tonsil, not for base of tongue, but what would you do? How do you assess them? How do you address them?
I would address them if there was anything suspicious. I would take them out, but I don't routinely try and take them out for a small tonsil primary.
Okay. Who else wants to?
Can I just ask you a question amongst the folks on the, just how many people with a concerning or convincing retropharyngeal node recommend surgery over radiation therapy or chemoradiation? I'm just curious.
That's a great question. Yeah. Usually I'm not. That makes me a little bit less enthusiastic. But let me ask others. Who wants to take that?
Yeah, I would.
Not surgery for us.
I'm sorry.
No surgery. Okay. Brianna?
I would agree with that. If they have a large retropharyngeal node or anything concerning, probably more likely to recommend not a surgery.
Anybody would not care. All right. Okay. Yeah, I think you can see, although there are differences, but there are a good number of consensus on these things. All right.
Are there other people who would elect to operate on this, even absent this patient's strong preference for surgery?
Yeah, I would. I mean, so again, a lot of it comes down with patient preference, but if someone is very motivated to avoid chemotherapy, then this is the way to do it. Yeah. And the other thing which you didn't mention is that today we can give this guy 60 gray rather than, 50 gray rather than 60 gray. So that's another reason to put him towards surgery.
And would you talk to your radiation oncologist about not radiating the contralateral neck now that you have proven that it is
If this man's holdup was the chemotherapy, and say that left-sided node ended up being needle negative, would he have been a candidate for radiation alone up front?
That's a little bit too big for radiation alone. I think most radiation oncologists won't feel comfortable radiating alone. The 4 centimeter T2, almost T3 nodes, and a suspicious node on the other one. I don't think so. Would any of your radiation oncologists would do radiation alone for this case?
I think technically it's a T2N1, and we do get away with single modality for select. When I say N1, I mean like AJCC 7 N1, not AJCC 8, where N1 could be like 5 lymph nodes on the clinical examination. So for T2N1, if it's under 4 centimeters, it's under 4 centimeters. Remember, I think was it AHN002 had a T3N0 criteria for radiation alone as an entry criteria. So the question of the slightly larger primary in the T3 space is still being explored with the data to come out. So I don't know if they would add chemo to the primary site based on it being close to 4 centimeters if you accept it to be a T2 to begin with.
And I have to say, Brianna, you adopted a very cautious way of doing this, and I think that's the right way to do. Even when you're dealing with a big tumor, bilateral neck, all that stuff, it's really important to be cautious and err on the side of being safe. And some people might have even break them, and that's not totally crazy, but it seems like you guys have become comfortable with the experience, and you did a great job.
Can I ask a question? Jeremy, you were referencing the 3311 results, I presume, that came out that were presented at ASCO recently.
Yeah.
That showed that de-escalation in the adjuvant setting, the less than 5 nodes in a negative margin showed equivalent. I think was it 2-year?
Right, 2-year progression free.
Yeah. I'm just curious, would you consider that now standard of care? And asking the group, have everybody's radiation oncologist adopted that based on those kind of preliminary results from that study?
I can't convince anybody to do 50 gray yet.
Okay.
I would love to, but that Memorial has the 30 gray trial that's been very successful, and we have all this data for years that they do 30 gray for anal cancer, and nobody is worried about that. But when it comes to head and neck and tonsil, we cannot convince them to do from 60 to 50 or 5500.
Yeah, we have the same problem here. So I actually had a long discussion with this guy preoperatively and made him meet with the radiation oncologist. And then I discussed with the radiation oncologist myself what dose he would give and what would he be willing to give and de-escalate to, because I wasn't going to touch it surgically if he was still going to blast him with a full dose of therapy. But I actually presented to a tumor board yesterday trying to get them to give 50 gray to some of these, and they also, that group wouldn't buy in at all.
Yeah.
So it's tough.
And I think the ASCO was really just, and I could be wrong, but I thought it was only 1 year. I think it's 54 gray. And although it looks really promising, I wouldn't say our radiation oncologist would consider it standard of care quite yet, as this is the first sort of delve into that data in that intermediate risk group that they looked at.
Yeah, I second Chad's comments that, I really want to see the paper to be able to sort of pick through the data. You really want to look at the methods. You want to look at the demographic groups. I think 3311 will be practice changing, and I think the abstract is compelling. But I don't think we're ready to sort of jump onto major practice changes with that data until we've all, like as a team, that had a chance to scrutinize it. But I'm very optimistic.
Perfect. Mike?
All righty. Brianna, do you have any additional comments about that case?
So I was just going to say we did give him 56 gray to the space of tongue, only didn't treat the necks because we considered his necks treated. He has been doing really well. He plays golf 4 times a week, eats a regular diet, and he's happy as a clam. He just walked his daughter down the aisle, so far so good. Oh, and then I wanted to say this is a great paper about, the occult contralateral nodal disease for the fellows.
I just want to comment on the placement of feeding tubes because I've evolved from early on where I placed them in everyone, which I think is fine, is a safe thing to do, and now we don't place them in anyone. And we just reviewed, this was data that we were not able to publish and or present in AHNS, but of our last 3 years and 130 some patients, and we presented, we only place NG tubes in I think 4% of patients. So as long as you have an engaged SLP team and you're not doing anything crazy surgically, then it's really not necessary.
Excellent. I agree.
Awesome. Well, thank you guys very much. It was a very productive session. These are some of certainly my longest conversations with patients. I think there's so many decision points and subtleties, and a lot of these discussions very important to have on the front end, so you're not kind of playing catch up or walking down a path that gives them extra toxicity unnecessarily. So thank you all for bringing out these excellent points. Thanks to our presenters, Bora, Brian, and Brianna. Great job. Really happy to have you guys engaged with it. Jeremy and Chad, thanks for being our kind of guest discussants. And then, as always, Jeff and Don and Arno and Babak, thank you guys very much for your involvement as well. Our next session's on September 2nd on parathyroid disease, so certainly look forward to seeing everybody then. Thank you, guys.
Thanks, guys.
Thank you.
Great session.
Have a good night.
Thank you.